Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
Hey.
I'm Justin Burt, joined tonight by Dr. Chris the Chew Man Chew, and we had a wonderful producer for this episode, Dr. Crystal Nora. Our guest tonight was Dr. Carissa Baker Smith to discuss pediatric hypertension, a lot of great pearls. But before we dive into content, Chris, can you remind us about the show?
Yeah. Well, we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine. And we are so lucky to have Crystal here. Crystal, who do we have to talk today? Tell us a little bit about Dr. Carissa Baker Smith.
We have a heart-racing conversation with our guest, Dr. Carissa Baker Smith. She's a preventative and transplant pediatric cardiologist who serves as the director of the Nemours Preventive Cardiology Program. She also currently serves as the chair of the Atherosclerosis Hypertension and Obesity of the Young Subcommittee of the American Heart Association Cardiovascular Disease. You'll want to take off your white coat and sit with your feet firmly planted for this conversation about pediatric hypertension. We will review screening guidelines for the blood pressures, initial workup, and the eventual treatment of hypertension in kids.
You know, Justin, the pressure was on this one, but I think we made it through.
Nice. High pressure. I get it. Dr. Baker Smith, thank you so much for joining us. We're very grateful to have you on the show. Welcome to the Cribsiders.
Thank you. Thank you for having me. This is great. I'm very excited to be here.
We're excited to have you and would love to get to know you better and have our listeners get to know you better. So to start out, we'd like to just ask some basic questions of kind of getting to know you. And so can you give us a little bit of a one-liner or describe yourself for our listeners and what are some things that you're interested in, maybe outside of medicine?
Sure. So my name is Carissa Baker Smith. I am a pediatric cardiologist. I am a preventive pediatric cardiologist. So I specialize in prevention of acquired cardiovascular disease. That includes high blood pressure, dyslipidemias. I also have a fair number of kids who have overlapping comorbidities like obesity and sleep disordered breathing. And I help them with the cardiovascular manifestations of those conditions. And I'm also a transplant cardiologist, interestingly enough. I'm a researcher with a math background. So I was a math major in undergrad and then did some cell and molecular biology work. So I have a master's in cell and molecular, and then I have another master's in biostatistics. And I do research about 40% now and 60% clinical. And then outside of that, because I know you wanted to know about outside of medicine, I'm a runner. Don't run quite as much as I used to, maybe about 20 miles a week. So not a ton. And I have run a marathon, ran to Baltimore under 4 hours. Very proud of that. And used to be an artist, watercolor, charcoal. Don't have as much time to do that. And I have 2 kids and a husband and a dog. He's a Shih Tzu and he snores. So you can imagine it's interesting in our house. My little one is a gymnast and my eldest has aspirations of being a teacher and she does some modeling. So it's a very interesting household.
Wow.
Nice. What's the name of the Shih Tzu?
His name, so we got him from a rescue. So he came with the name JT. So Jay and T.
Oh, nice.
Like Mr.
Nice.
T, but JT. Yeah.
Very impressed by the Baltimore Marathon. I did the Baltimore 10-miler once and was destroyed. And I think that's as far as I'm ever going to get as far as long
See you on the
distance running.
end. I'm telling you, the marathon, they wait till the end and then they have the hills. You're like, really? You make it around the lake and then it's like, that's like 21. And you're like, okay, no, this is not fair. Like,
the Baltimore 10-miler I did, my clinic preceptor, Dr. Katie Shaw, also did the 10-miler at the same time and beat me by about 35 minutes, which everyone teased me about. But she was also 35 weeks pregnant at the time,
Oh my
32
gosh.
weeks pregnant at the time. So that was my very humbling. Never again. That was.
Hey, we
it's
all have.
It's all Peloton here on out.
Well, you know what? You did it. You did it. You got out there and you gave it your all. That's good.
I once watched the marathon. It was very thrilling.
He's like, I watched it. Hey, it's a lot. You know what? I tell you though, I think it was one of those things on my list and I did it. I don't know that you're tired at the end for sure. Like half marathons, you can go about your day. That full marathon, I was pretty toast for the rest of the day. It was
Believe it.
quite the yeah.
I believe it.
So my question is there something recent that you read, like a book or something in pop culture, which you really enjoyed that you want to share with our listeners?
Oh gosh, there's so like I am a firm believer in just doing things that feed the soul. So I love like Harlem Renaissance poetry. I like all sorts of books. I read Michelle Obama's Becoming. I've read recently. There's some books on leadership that I really liked. Yeah, I just read a bunch of different things, whatever kind of suits me. And I usually don't read one book at a time. There's usually like 3 at a time. So I think I have 2 leadership books and another one by another author right now that's on more social structure, social dynamics. So that's interesting. Yeah.
Great. Let's dive into some content. Yeah. Let's talk about pediatric hypertension. And Dr. Crystal Norup did a wonderful job putting this amazing case for us together. And we're just going to jump in, starting with our first patient, Elena Prill. Elena is a 12-year-old child presenting to Cashlet Children's Hospital for just a regular well child visit. You're looking through their chart prior to the visit, and you do find a blood pressure reading it's at the 90th percentile for her age. On today's blood pressure reading, it is also elevated, and you're realizing this is something that you might need to be addressing in the visit. And before we go into the diagnosis and treatment, can you kind of walk us through what are some common pitfalls in measuring children's blood pressure? Is there anything about actual measurement of blood pressure that might be throwing us off and giving us a false positive or anything like that?
Oh my gosh, there's so many things. Most of the time, the measurement is not done correctly. Actually, so when we actually did the guidelines, you'd be surprised. Like there weren't any photos of demonstrating how to appropriately measure a blood pressure in a child. The arm wasn't at the heart level. The feet weren't planted. They were measuring it in the left arm. Arms kind of free floating in space, unsupported. So there's so many things, and all of these things contribute to the blood pressure being elevated, not to mention the child's nervous. So there actually was a study where they looked at like blood pressure that was measured by like the medical assistant or the nurse or whomever was measuring it first. And the kid walks right into clinic. Maybe they're running late. The kid's mom's like, come on, we got to get to the office. We're late. They rush in, they sit down, somebody measures their blood pressure and it's elevated. So they haven't had their like 5 to 10 minutes to sit with their back supported, their feet planted, their upper arm at the heart level, and they measure the blood pressure and it's elevated. A lot of times too, the wrong size cuff is used, so that can also impact the blood pressure. I had one kid who was like making a fist like the whole time they were having their blood pressure, checked. Like, nope, you don't want to make a fist. So all of these things impact the blood pressure measurement.
So how big should the cuff be? How can we estimate when we're using it on a patient?
Yeah, so look at the bladder. That's the inflatable portion. You can hold it. I like holding the width up. So the width should be about 40% of the arm circumference. So if you just look at the top part of your arm, you hold the cuff up, the width portion, and just wrap it and just make sure it covers at least 40%. And then the length of the bladder should be 80 to 100%. It's better to size up than size down. So you're more likely to overestimate the blood pressure if the cuff's too small and less likely to underestimate it if the cuff's too big.
Great.
Excellent.
And so let's say we have done a QI project in our clinic. We are certain that we're getting a appropriate blood pressure measurement. And sure enough, on repeat, we try to repeat it to make it go away like any good physician does. But after repeating the blood pressure, we're still right at around 90th percentile for age. And so now we're bringing this to the forefront. Can you talk to us a little about what is pediatric hypertension? Is she hypertensive? How is this defined? And how should we be kind of approaching it when we see a patient with an elevated blood pressure like this?
Yeah, so elevated is different than high. So when we redid the 4th report, we did the 2017 Pediatric Hypertension Guidelines sponsored by the American Academy of Pediatrics. So What you'll see in that document is a nice table that kind of characterizes what blood pressure normative values are and who has sort of normal blood pressure, what's elevated, what's stage 1, what's stage 2, which is the highest level. And it differs by age. So if you're 1 to 13, we still use normative data. So what that is we took a population of about 40 kids with the 2017 guidelines. We took out the obese kids, the kids with obesity. We basically said, what's the median and then the 95th percentile, so on and so forth. And so based upon height and age. And so it's really looking at mainly your height and determining whether that measurement is appropriate for you or not. Now, the difference is that once you turn 13, and this is where the change occurred with the new guidelines, is that we saw there was an issue. It was possible before where you could have a normal blood pressure, or say a elevated blood pressure, say it's high blood pressure as a kid, and then suddenly you entered the adult guidelines and you were considered to have a normal blood pressure. So at 13, though, things started to align. So we basically redid the classifications. And so at 13 and above, the guidelines go along with the adult guidelines. So if your blood pressure is less than 120/80, so systolic less than 120, diastolic less than 80, then it's normal. If your systolic is between 120 and up to 130, or 120 to 129, then that is elevated. And then 130 and above, or 80 diastolic and above, is high, stage 1. And then above that, 140 and above, or 90 and above diastolic, is stage 2. So that was sort of reworked. And then if you're younger than 13, then it has to do with the percentile. So if you're less than the 90th percentile, that's normal. If your blood pressure is between the 90th and up to the 95th, or up to 120/80, then that is, whichever is lower, then that's elevated. And then stage 1 is where you go from greater than or equal to the 95th percentile up to less than the 95th plus 12 millimeters of mercury, or the 130 to 80/139 to 89, whichever is lower. And then the stage 2 is greater than the 95th plus 12, either the systolic or diastolic, or greater than or equal to 140/90. So it's easier to see the table, and it's also easier if you're 13 and above to remember, but to suffice it to say that we use percentiles for the younger group when we're looking at in-office blood pressure. So that's separate from ambulatory blood pressure monitoring. That's in-office blood pressure measurements.
What exactly is the reason for the stratification between the elevated blood pressure, the stage 1 and stage 2? And is there a purpose for that?
Yeah. So it does have to do with some of the data we have about vascular changes. So it's not normal to have elevated blood pressure. There are some vascular changes that can occur, some stiffening of the blood vessels as seen by pulse wave velocity. When you're hypertensive, though, that's when we really think about target organ damage and long-term risk for heart disease, including heart failure. So that number really does track forward. And we are learning more about the relationships between blood pressure in childhood and adult onset heart disease, but that's where that relationship matters. So it also matters because we don't want to treat everybody, right? Like you don't want to put every kid on medication, but you definitely want to address the kids who are more likely to develop some of that target organ damage, whether that's increased mass of the heart or, adults we know to go on to have like heart failure and increased mass and all of that. So it's that relationship between what we know to be the long-term consequences of high blood pressure and then trying to track that back into childhood so that we're preventing disease, if that makes sense. Yeah.
And so you mentioned for this diagnosis, it sounds like for 13 and above, we almost treat it like an adult. For the other age groups, you mentioned in-office blood pressure readings at 90 or 95th percent. What is the difference between office blood pressure monitoring and ambulatory blood pressure monitoring? And when do you start thinking about using the ambulatory blood pressure monitoring? Can you talk a little bit about that?
Yeah. So for people that don't know, so basically when you take your child or, you're a provider and you're in the office, so the device that you're most likely to see initially is an oscillometric device. So that's an automated device. Each company has its own algorithm. It calculates the mean arterial pressure, and then depending on the algorithm for that company, that calculates the systolic and the diastolic blood pressure. That's one way of checking in office. So that's while the child's in the office, seated in front of you, again, proper position, all of that. Manual blood pressure is used to confirm. So sometimes those oscillometric blood pressure measurements are not quite right. So then you're using the Karat cough sounds from your either mercury or manual. I don't think many places have mercury cuffs anymore, but anyway, manual blood pressure cuff. And then those are the ones you use in the office. The ambulatory blood pressure monitors are oscillometric devices, but you send kids home with them, and they wear them for 24 hours, usually in the non-dominant arm, which is a little different, because in the office, it should be the right arm that you're measuring the blood pressure in, assuming they have a normal aorta, which is most people. But if you're monitoring blood pressures at home, the gold standard to distinguish white coat high blood pressure, which is I have high blood pressure in the office, but my blood pressures are normal at home, is to use this ambulatory blood pressure monitor. And so, like I said, it's an oscillometric device. It goes around the arm. Kids wear it for 24 hours and it records blood pressure. And we get lots of data from it. A good set of measurements is 40 to 50 measurements in a 24-hour period, both during the day and at night. So that's really a great way to determine if somebody has, like I said, the white coat hypertension or elevated blood pressure, where their blood pressure is just elevated because they're nervous in the office, right? First time, second time seeing you, and whether or not they truly have blood pressure that's high or elevated at home. So that's the difference.
And when are you considering using these as opposed to just making the diagnosis and starting treatment? What role does the ambulatory blood pressure monitoring play with the new guidelines?
Yeah, so it's really used to confirm the diagnosis. I mean, if you have a situation where the person comes in and their blood pressures are high on repeated visits, usually it's three, we usually require 3 visits, then you don't necessarily have to move forward with the ambulatory blood pressure monitoring. But if you suspect that the child the blood pressures are elevated, not because the child is hypertensive, but because they're nervous, they have white coat effect, then it can be helpful. Sometimes what I'll do is, even though in pediatric practice, which is different than adults, in adult practice, there are some in the guidelines, some recommended use for like home oscillometric devices. Those are like the devices you buy at like, Amazon or Walgreens or, wherever, your local pharmacy. We don't use those as readily for kids because a lot of times for little kids, especially, the cuff sizes are not available for them. So those smaller cuffs are not available. So you don't know the accuracy of the measurements that you're getting. The way of measuring it really should be the arm. But if their home blood pressure is usually using somebody's like oscillometric device is a little elevated, sometimes that gives you a clue as well. It's usually as supportive data, not as diagnostic data, to help with whether or not you need to proceed with that next step. Or if you've gotten a lot of variability in your measurements, sometimes the kids come in and the blood pressure's high, and then other times they come in and the blood pressure's normal. Then sometimes the ambulatory blood pressure monitoring can be helpful in that case.
So, one question I have is when I do ambulatory blood pressure monitoring in, say, my adults, I think we have slightly different cutoffs for what we consider like hypertensive. Is this true with pediatric ambulatory blood pressure monitoring as well?
It's true. They're very different. Because it's embargoed, I can't talk too much about the new guideline that's coming out for
Ooh.
ABPM. Yes, to answer your question, there are some differences between how we define abnormal blood pressure, and from in the office, and then how we define it using ambulatory blood pressure. The tables are different. They're not the same.
And while we're still on the topic of diagnosing and figuring out the accurate blood pressure, can we go back to say, when are we checking blood pressure? Should we be doing it at every annual? What about sick visits? Should we be checking blood pressure at sick visits?
Yeah, so it's a tough. We talked about this when we were creating the guidelines. So, it should be at every well child visit that the blood pressure is assessed, and certainly for kids who are maybe have risk factors for heart disease or for high blood pressure, it should be checked, starting as early as possible. For everyone else, it's about 3 years of age and above. But yeah, pretty much every well child visit for just straightforward cases. If you have a child who has maybe some risk factors for high blood pressure, like kidney disease, or you suspect coarctation of the aorta, or they have congenital heart defects that are known to affect the aorta, then it's definitely you want to check blood pressures at any visit, because you're monitoring their blood pressures carefully. But in general, it's every annual well child visit, or when they're younger, they have more frequent well child visits for vaccinations and things like that. But yeah, that's typically what we recommend.
And I know, at least in our resident clinic, if you have a pediatric patient, if they're 9, 10, 11, 12, and they're hypertensive, the first thing that everyone wants to talk about and start pursuing is a very comprehensive workup for what's called secondary hypertension. Can you explain to us what is primary or essential hypertension versus secondary hypertension, and when should we maybe be leaning towards one versus the other?
Yeah, those are really good questions. So, obviously your exam is so important. So if you have, and this is true whether a child is young or old, but if you have a child who's under 6, for sure you're thinking, could this be a secondary, meaning they have some other condition that's causing them to have high blood pressure, whether that's kidney disease, which is the most common, like I mentioned, coarctation of the aorta, which is a narrowing in the aorta that's just near where the PDA, the patent ductus arteriosus, arises in utero, but narrows down near the aortic isthmus. There are times when there are endocrine related causes of high blood pressure, like tumors that make stress hormone, so like pheochromocytomas, thyroid disease. Sometimes medications can contribute to the blood pressure as well. So like steroids are a big one. But basically, secondary high blood pressure or hypertension is when there is another reason for the child to have high blood pressure. And then primary hypertension is really it's primary, meaning there's either there's a predisposition to salt and water retention or increased vascular tone. Sometimes there's genetic reasons. I kind of lump obesity related hypertension into that, although it's obesity related. But yeah, so that's the difference. And when there's secondary hypertension, the treatment is addressing that condition. So if it's like hyperthyroidism, or if it's some sort of kidney disorder, you're addressing, if it's coarctation, you're addressing the cause, versus like in primary, there is no cause to address per se, unless, like I said, obesity related, you're going to counsel on healthy diet and weight loss, but it's different than like a secondary case. So that's the difference between the two.
And so maybe as in our case, as a case example, to kind of pick the low-hanging fruit first. Let's say Elena is an 11 or 12-year-old. She is in the 95th percentile for her weight. She has a strong family history of high blood pressure. She has a lot of other of those kind of obesity-related comorbidities. For these patients, what does the workup entail? Do we need to be looking for secondary causes, or can we say this is primary hypertension?
So you always want to, certainly it's easy to say in this case, it's probably obesity related, right? So you want to do your due diligence with assessing the blood pressure. Sometimes even slight changes in weight, it doesn't have to be dramatic changes, but even slight weight changes in weight can have an impact on the blood pressure. So you're always proceeding with lifestyle counseling. But it's also true that don't be fooled that every person with obesity necessarily has hypertension just because of obesity related hypertension. Sometimes there is thyroid disease in addition to, or sometimes there is, and I've seen that, or there's coarctation. So nobody picked up on it because nobody checked pulses in the groin to see if they were the same quality as the brachial pulse. the quality and whether there was any delay. So you definitely want to have a high index of suspicion of other potential causes. But in large part, most of the cases that we see, particularly in older kids, so your 11-year-olds and so forth, it's going to be, if they have obesity, it's related to that. Family history, sometimes the way that I look at that is, the choices we make, sometimes the foods that we eat, the amount of food that we eat, how we eat, when we eat, we learn. And so sometimes those behaviors are passed on to kids. So preference for high salt foods, high fat foods, lack of physical activity, can also play a role. There are some, genetic syndromes that contribute to high blood pressure, but in large part, when you see families, my experience has been it's some learned behaviors there as well.
This might actually be an okay time to ask. In our mission as a medical education podcast, we work to identify racial disparities, racial inequalities that go on in medicine. And I know especially in adult medicine, this is something that comes up a lot in hypertension, where the adult guidelines incorporate race. In pediatrics, can you talk about racial disparities in pediatric hypertension?
Yeah. Well, stay tuned for some of my results from some of my studies because we're
Great.
looking at some other aspects of this. Yeah, it's a sad to say, but, there are biases in medicine, and they do carry out in terms of how we practice medicine. And being a African American woman myself, I can say I don't know that any such things are always intentional. I think sometimes it's the way in which stories are obtained, histories obtained. There's so many different factors, but I would say that first and foremost, race is a social construct. There's very little genetic basis, and I know that's controversial to many people, but it's true. I mean, there's some very good studies looking at that, and from reputable journals like Nature. So I don't think that's a surprise to anyone. So when you talk about social constructs, then and race being a social construct, so how does that interplay with the diagnosis and the treatment? It's probably multifactorial. Certainly, if I live in environments where I am maybe access to healthy foods, safe places to exercise, that can play a role. Empowerment to make changes, perceptions of health, perceptions of what's being reported, allowance for certain tolerance of certain values, or parental reluctance to treatment. So, unfortunately, we do have a history in this country of some not so nice things happening to people of color, in medicine. And so that, it doesn't seem like, it's like, well, that happened so long ago, but memories last long sometimes. So, some of that plays into it as well. So it's a very complex story, but there are some, when you look at some well-published studies, like every year, there's a published study looking at heart disease in the US and globally. So Varani et al. 2021, for instance, looks at just globally and in the US prevalence of disease. And when they break it down, hypertension prevalence by race, you do see some disparities there in terms of age of both in youth, but also in adults in terms of the prevalence of high blood pressure and heart failure and heart disease. For adults, late to diagnosis, tardiness to diagnosis, I think, has a major impact on the prevalence of, say, heart failure and heart disease, stroke, heart attack. But it's true of a lot of populations. I mean, one of the other areas that I study is dyslipidemia. 90% of people with familial FH don't know they have it, and that's all comers. So it is complicated, but there are differences in prevalence. I don't think it's different when we're born, although I will say that we do know that things like maternal preeclampsia and maternal gestational hypertension may have an impact on the vasculature of the fetus and the risk for the child developing hypertension later. So this idea of primordial prevention is also important and something that we're looking at more. We actually have a review article that touches on some of those topics. And one of my mentors, Bonnie Faulkner, she has another nice article on primordial prevention. So talking about some of those aspects of how disease starts. So the best thing that we can do is, I think, as for trainees, is to teach. And I'm a firm believer of this. Don't present your patients as 10-year-old African American kid. Don't do that. I think that it sets up. Unfortunately, we haven't advanced as a society enough, I think, where we're able to kind of not jump to certain conclusions when you hear those things. And I know it's not going to be a popular thing. Everybody's going to be like, oh, that's not true. That's not true. But it is true, at least for some. And so I think that we have to be aware of that. We have to be aware of our own internal biases, because we all have them, and make sure that that's not interfering with the care that we provide. And I think if we do that, then we as a group and collectively can help address some of these disparities. I also think it takes education, educating communities about some of these topics. So that's, I was very happy to be invited to be a part of this podcast. But I think, getting the word out to communities and to people, because even very well-meaning, like adult cardiologists, you're like, oh, I had one cardiologist come to me and he's like, did you know that hypertension starts in kids? I'm like, actually, yeah, I did. Like, like it's, it's, so it's interesting because people think they're kids. Why should they have these things? Why should they have heart disease? Why should they have high blood pressure? Why should they have high cholesterol? But they do. And we have to think about that. Sorry, I think I was on like a little soapbox there.
I just appreciate the answer, and I appreciate the insights.
I guess the next question would be like, what exactly does the workup entail for the secondary hypertension? So you have maybe a suspicion, like and you maybe have a red flag here and there. Like, what do you do next?
Yeah, so you're trying to get to what is the cause, right? So you're looking at thyroid. You're looking at renal function. You're looking at their physical exam. Do they have cafe au lait spots or axillary freckling? Do they have signs of, tachycardia and, signs of a pheochromocytoma? So, you're looking at these potential reasons that the blood pressure can be high, and sort of in a systematic way. The way that we sort of break things up, that CASHLAC, I won't say our institution, but we have various groups. So I'm a preventive cardiologist. We have nephrologists, we have endocrinologists, and a weight management program. So if they're 6 and below, especially if there's a history of premature birth, they see the nephrologist first. And the nephrologist does their workup for causes of renal vascular hypertension. Renal ultrasounds aren't always the best, but you're not going to do like angiography or CT on everybody, right? So you want to kind of figure out who has what. And sometimes you start with a renal ultrasound, but it may not be where you finalize the diagnosis. Thyroid studies, like I mentioned, and like I said, your physical exam. Sometimes you'll send urinalysis. You definitely want to check those pulses, upper versus lower extremity pulses. The quality, is there pulsus tardus, where there's a delay on the onset of the femoral pulse versus the brachial pulse. Just sort of starting from head to toe. Or do they look cushingoid, like they've been on steroids? Do they have any enlarged thyroid? Do they, have rashes that maybe are suspicious for, things like neurofibromatosis. So I was mentioning the axillary freckling and things like that. Any abdominal masses, things like that. So there's a whole list of causes that we put into the 2017 guideline. So it's always nice to just refer to, or maybe keep it as a dot phrase to remind yourselves.
Now, do you get anything like EKG or other types of imaging outside the renal ultrasound?
Yeah. So in terms of from a cardiac workup, in the adult guidelines, EKGs are recommended. EKGs actually have a very high false positivity rate for things like left ventricular hypertrophy. So if the nurses, if they put the EKG leads just a little too far to the left, everybody has LVH. So we don't use that actually anymore. In adults, they use it because they're looking for things like atrial fibrillation. So we did not keep that in the 27 guidelines in terms of the EKG. Now, we do use other imaging for diagnosis of like coarctation of the aorta or mid-aortic syndrome, which is another vascular cause of hypertension. But we're also using echo for assessments of any signs of target organ damage, which is left ventricular hypertrophy. So, to your point, the diagnosis of coarctation, for instance, is you suspected based upon the exam and blood pressures. You have a higher blood pressure in the upper extremity, usually the right arm, versus either lower extremity if they have a right aortic arch, right? And then the echo can be confirmatory. The other reason you can have that is not as common, but we do have some cases at Kashlak, is mid-aortic syndrome, which is a narrowing in the descending aorta, which also gives you, higher sort of upper extremity and lower extremity blood pressures, but just not as common. That can also involve the renal arteries as well. And then, like I mentioned, from the secondary effects of having high blood pressure, then we're measuring left ventricular mass and looking at those aspects as well, function as well.
And so it sounds like for these individuals with hypertension or high blood pressure, you're really doing the good physical exam of all the great physical exam pearls you mentioned. You're maybe starting a little bit of the initial workup with things like thyroid studies, especially if you're concerned, or it sounds like for sits in a younger, renal causes seem to be higher on the list. And so maybe, right, is that right? So maybe a BMP, checking the urine, and the renal ultrasounds, but it sounds like those are not completely keeping you out of the clear. So am I hearing right that you almost say if it's a 5-year-old with hypertension, you're pulling the trigger and doing a nephrology referral? Justin, if you want to order a BMP, a UA, and a renal ultrasound, feel free, but that kid needs to see a urologist or a nephrologist to see if there's other imaging that needs to be done.
I would. That's been my practice. I'm not trained as a nephrologist. I work very closely with them. Just like if we suspect coarctation, I would expect that they would send those kids to me. But it's important because, or if it's an endocrine related, cause, you want to make sure you have your subspecialist involved. Now, if you are operating a place where you're remote and it's just you, then there are steps to take. In which case, I would say, you're starting with your laboratory testing if it's renal, and your renal ultrasound and size of the kidneys and cysts and things like that. And then if there's any suspicion from the renal ultrasound, or you still see that there's, very significant hypertension, maybe you're moving forward with like some further diagnostic imaging. Just like if you suspect coarctation, you're going to be getting an echo and moving down that path. So the guideline is pretty comprehensive in terms of things to look for. And I think whenever you get to a point where you're less comfortable, you should definitely seek the consultation with a colleague that maybe is a specialist in the area, maybe has seen cases before, but definitely get some advice there. But for the older kids, you have a 13-year-old, or in this case an 11-year-old who's obese and they have high blood pressure, you're going to look to see what impact you can make. And you've checked for things like, you check the quality of the pulses, you checked they don't have any abdominal masses, you've checked their skin findings and all of that. I mean, you're still going to do a detailed physical exam, but then after that, if they're still hypertensive, maybe it's stage 1, not stage 2 or more, then you might give some time and allow them to make some lifestyle changes. The other point I like to make is the more severe the hypertension, the more you want to think about secondary causes as well. So you've got a kid where the blood pressure is super high, like, they may not be symptomatic, but it's 160 over 110. It's pretty high. So you're not going to just send that, kid home and say, okay, well, let's see. You're definitely going to repeat the measurements. And you're definitely going to look to see whether or not there are some secondary causes in that case as well. But in large part, what you'll see is lower numbers than that, especially if it's, something related to like obesity or one of those types of causes, the more common causes.
And it does sound like you're really mentioning the equal pulses as a key finding or a key thing on physical. If they have good pulses, femoral pulses, left pulses, right pulses, does that rule out most vascular? If they're not an abdominal bruit or mass, or those things where you can safely say this is probably not a vascular secondary cause?
Yeah, you have to be really careful depending on the age. So you definitely want to check upper versus lower extremity blood pressures. And, anytime you're, evaluating for hypertension and you suspect that the blood pressure seems higher than you would expect, the person's not responding like you would expect, you want to think about, is there something else that you're missing? And I've definitely seen, a case where it was just like a 17-year-old who presented late, I think to an adult cardiologist for hypertension, and was treated as though they had just sort of run-of-the-mill hypertension, and come to find out he had coarctation of the aorta. So there are going to be some other signs there, murmurs on exam, maybe, signs in terms of the pulses, in terms of the blood pressure gradient. So there's going to be some other, other signs that maybe something is more than just your run-of-the-mill, like, primary hypertension.
So it sounds like, say we have a patient and we decide that she has, primary hypertension here, or, and you want to really pursue like lifestyle modifications. What does that counseling sound like? And how do you take into account like financial issues, health disparities as you talk to parents and the child, if they're able to, about what these lifestyle modifications look like?
Yeah, so my approach is a really comprehensive one. And I have to say, I just want to take one moment to say that, and maybe I know lots of providers do this, but I make it a point, and when I'm teaching trainees, I make it a point to, stress to them the importance of getting to know each child as an individual, because a lot of where your lifestyle intervention is going to come into play is recognizing where that particular, where you can meet that child individually. So sometimes, like today I had a patient, and they're like, look, it's just not safe for us to go outside. Like, it's just, we live in a very busy street. Like, no, we don't have access to a gym, but we have some other things. Like in this case, they actually had they had a little treadmill in the house. Or sometimes the kids, what they have is their phones, right? And they go on TikTok, or they go on YouTube, or they go on some social media platform, and there's music videos and things they can dance to, and they like to dance. So I try to find the things that they are interested in when counseling. But we also talk about, in terms of like diet. I have a slew of handouts, and I have some like, recommended diets where it's sort of, there's some cultural diversity to it. So there's like some different types of foods. And so, it's important to kind of, but talk about what constitutes sort of a healthy composition to the diet, the importance of reducing salt, and I would say the closer to the ground, the better. So like, like fruits and vegetables. And I used to say vegetables and fruits because everybody's like, well, I like fruit. But anyway, so, so trying to like find areas where, you can make some headway. And I also make it a point to find something that they're doing positive. Because I don't know about you, but for me, like if you just say, oh, you've got these like 10 things that you're doing wrong, well, I've already like blocked you out, right? Like, you don't do this, you don't do that. Like, okay, block. So, but if I'm saying, oh, you walk your dog 3 times a week. Oh, tell me about your dog. Oh, that's so great. Do you think your dog wants to go on a little bit of a longer walk? How about like if we 45 minutes, like, could we do that 5 days out of the week? They're like, oh, well, and so you try to like find ways for them to feel motivated, and you put it in their shoe. Like I've had kids who said, I had one, like, for a while I was like, why don't you make a little vision board? Like, where do you see yourself? Like, where are your goals? Put some positive quotes. I had one girl come back. She had her notebook. She had her vision sheet. She had all her positive quotes. And then behind it were like sheets where she had put like, she decided on her Apple Watch she was going to record how many times how many minutes she reached her peak heart rate, and the amount of time that she was exercising. And gosh darn it, she lost a fair amount of weight and felt better, and she felt good. So the lifestyle intervention needs to be something that resonates with the kids, and each individual kid. And it can take a little time. And then you're also like addressing some of the barriers as well. So you're also getting a glimpse into what the household is like. The other key thing that we found too that can be very helpful is encouraging family members to eat together. So you're less likely to overeat if you're eating with someone, right? So even if mom or dad works late, or maybe they work the night shift, say, oh, the night shift. I said, do you have a brother or sister there? Yeah. Could you guys eat dinner together? okay, they try it. So that can make a difference in you giving some social structure to them. We talk about not eating too late at night. We talk about what they're drinking. We talk about ways to sort of more focus prescriptive changes. Sometimes it works, sometimes it doesn't, but you're trying to at least sow the seed. And you'd be surprised. Sometimes kids do make some pretty substantial changes to their diet and lifestyle.
Awesome.
And so let's say that we meet Elena where she's at. She's doing TikTok videos. She's completing her circles on the Apple Watch. She's really giving the lifestyle behaviors a adequate try. We bring her back in 6 months to see how she's doing. And unfortunately, we're rechecking the blood pressure, and it's still pretty elevated. It hasn't moved too much. At what point do we say we need to pull the trigger and start pharmacotherapy, or are there other diagnostic tests that we're ordering at this point? How are we approaching this patient who is compliant or is able to pursue lifestyle management but doesn't seem to be getting the blood pressure benefits that we're seeing?
Yeah, so basically, what that kind of boils down to is we also have to look at how significant the blood pressure elevation is. So let's say let's say you're not quite sure that it's white coat versus, say, stage 1 hypertension. So high, but not super high. You can have them wear ambulatory blood pressure monitor, but if that's abnormal, and you've gone through your diagnostic evaluation, then you're going to consider initiation of treatment. Now, this is when the question becomes for the provider, right? So if you're a general provider, you feel comfortable, okay, start. But make sure you're comfortable with that your measurements are accurate. Once you start medication, for me, it's really challenging to kind of backtrack. So I hesitate to stop medications if they've already been started. So for me, it's helpful at that point as a preventive cardiologist if they're referred. So maybe the pediatrician's already checked at least 2 and they're like, they're pretty high. Maybe they checked a 3rd and they're going to refer. That's helpful for me because then I have a sense, an ability to kind of assess pre-medication where we are and kind of check things. But let's say you're the provider, you feel comfortable, you're pretty sure, then yeah, sometimes you do need to start medication. And as always, start low. You want to start with a medication. You want to explain the reason why you're starting it. And again, that's when I go into with parents, like, why do we treat high blood pressure? What are we trying to prevent? I talk about, the American Heart Association's Life Simple 7, which is not so simple, right? So it's 3 health factors, 4 health behaviors. It's your, blood pressure, cholesterol, blood sugar, and the behaviors are your weight, your exercise, your smoking, and your exercise, diet, smoking, and your weight. So then those are the 4. So you want to address all of those things, and then you say, well, look, they've got a major, hypertension is a major contributor to heart failure and heart disease, and so we treat it to help preserve the function of the heart in the long term. And so we've tried lifestyle. It hasn't been as successful as we'd like. We continue to recommend lifestyle changes, but we need to start your child on a low dose blood pressure lowering medication. And people have issue with that. I know not everybody feels the same, but we do know that blood pressure can track into adulthood, and there's some great studies that have shown that. So low dose once a day, preferably, because it's easier to administer. So lisinopril or like a calcium channel blocker. Those are some of the ones I typically start with, like amlodipine, just because they're once a day. And then we bring them back, we reassess the blood pressure. Always get an echo before we start medication. Again, you're looking for baseline mass, you're looking for any signs of coarctation or any other structural changes and or structural abnormalities before starting the medication. And then and then we follow them. Sometimes you need more than one, unfortunately, too.
And just to clarify, sorry, the 13-year-old, again, with this, essential with obesity-related factors, family history, no clear signs of secondary hypertension, and we, feel like it's likely primary. Are we still getting an echo on these kids before we start pharmacotherapy?
We've recommended that, and I think it's helpful because what you're looking for is any sign of target organ damage at baseline, and periodically we'll repeat it. It's not common, but it has been reported that there can be kids with hypertension and decreased function. So I have one teenage girl who I follow now who has pretty significant high blood pressure. And she came to me sort of in an inpatient referral, but lots of comorbidities, including very severe obesity. And it's been a difficult time managing that. You talk about lots of the social factors that go into obesity. We have a psychologist and we have other subspecialists that work with us. I have a dietitian that works with me. I'm very thankful to have these resources available to my patients. But despite that, it's been a challenge. And so, but she has poor function. And I think in that case, there's other reasons. We did genetic testing and things like that, but you can see that. One of my mentors reported on the same, before he retired, cases of seeing decreased function in some of the kids with hypertension, but it's not common. Usually what you see, there may be some elevations in the mass of the heart, but you want to have that baseline information. And again, looking at the structure of the heart before starting the medication.
Now, talking about medications a little more, is there, so sort of a combined question I have. One is there an age where I'm like, as a pediatrician, this is way too young for me to start a medicine that I feel comfortable with. These should definitely be going to cardiology or nephrology for management. And then, so that's the first part of my question.
Yeah, no, I still, so, again, you want to make sure you're not dealing with secondary causes. Like if a child has renal artery stenosis, gosh, you want to be really careful about that. So what you're using to treat. So then that's where your nephrologist is going to be so helpful. So I definitely think the younger the kids that they have this, especially if it's significant hypertension, you got to think beyond this is the run of the mill hypertension. You've got really high measurements. They're stage 2 and above. You want to think, gosh, I really should have this child seen by a subspecialist. And sometimes the renal evaluation is clear, and sometimes it's endocrine related. Pheochromocytomas are not that common, but there are reports and there are other endocrine related conditions that you want to be aware of as well. So if the blood pressure is really high, don't ignore it. That's the first thing. Don't just think, oh, the kid's just nervous. You definitely want to work it up. And you don't want to necessarily just treat in those cases. Again, you want to make sure you go through the due diligence of thinking about secondary causes.
And as you're talking about, so say we've ruled out secondary causes and we're just having just a very resistant hypertension, and you've already looked and made sure that, even though it's a kid, they're adhered to medications and they're taking their medicines as they should be. You said that, an ACE inhibitor and a calcium channel blocker seem to be sort of your first lines. In your own practice, what does that progression look like? Is it, depending on what they're looking like, calcium channel blocker and then ACE inhibitor and then thiazide diuretic and then beta blocker? Like how, for you personally, like how does that look?
Yeah, it's a good question. So primarily when I see more of the resistant, so we'll call it resistant, although I'm using that term loosely. It's not quite the same as what we describe in adults, which I believe is like 3 or more antihypertensive medications, including a thiazide diuretic. I will tell you my practice has been, and we published on this as well, that there's some cases where you have to use obviously more than one antihypertensive agent, and these are usually not always, but usually if as long as heart structure is normal and kidney function is normal, you're talking about some other comorbidity like obesity that just is interplaying with the blood pressure, and the more obese the child, it's sort of like this parabolic sort of increase in risk for hypertension. And so the agents that I use, if I start with a calcium channel blocker, I might add a hydrochlorothiazide if they're obese with that, or likewise, or if I have a ACE inhibitor on board, I might add a hydrochlorothiazide on board. It does depend on the situation, though. So if I have like a post-transplant patient, right? Some of my transplant patients have hypertension. I tend not to use ACEs as much because some of the other medications we use can be nephrotoxic, like the tacrolimus. So I try to use a calcium channel blocker first, but if I need to, then I'll add an ACE inhibitor on board for them, which is a little different than like a kid with obesity. the way I stack the medications if I need to. And again, you're still all the time doing your counseling about, salt and diet and other medications and other things that could be contributing to the blood pressure. So it's kind of like the circle back, right? You always make your diagnosis and you make sure you've covered everything in your first circle, and then it's not quite responding like you think it should. You circle back and make sure, did I miss anything? Is this, did we look at all these particular aspects? And then you keep going forward. And you should get a response. I mean, you should be able to control the blood pressure if you've addressed it appropriately.
Anything else that Dr. Baker Smith you can think of that in a episode about pediatric hypertension we should be talking about that we haven't discussed yet?
There are situations of, really extreme elevations in blood pressure. So, I don't think that's the focus so much of this podcast, but like your hypertensive urgencies and emergencies. So that's something to be aware of as well. There are times when, you do need to send that child to like the emergency room setting, to be, to have the blood pressure addressed, because the blood pressure is just so high. And again, you don't want to ignore that. And usually with the urgency, there's minimal or no symptoms. The emergencies is where, there's some signs of organ damage and symptoms. So there are some times when, it does require, sending the person into the emergency room setting and inpatient to have the blood pressure assessed and managed. We've had cases where there've been like, endocrine adrenal tumors and things like that. So it's just important to pay attention to that as well.
And are those in cases where there is clear signs of end-organ damage similar to adult, or is there a cutoff where if you have a 13-year-old with a systolic over 160, they need to be seen more urgently?
Yeah, so really, I mean, once you're in sort of to that stage 2 range, I mean, you're talking about pretty elevated blood pressure. So you're paying attention to your 140s over 90s, but certainly like the 160s over 100s, those are really high. I'm trying to remember how we defined it in the guideline, but I think it was like, it's these blood pressures are pretty high. So it's something where you don't want to ignore that.
Awesome. Sort of as we wrap up, one of my favorite last questions is, what do you see in the future of hypertension management? What research do you see coming down the hill, or what any new medications? What are the things that make you excited about management of hypertension in pediatrics?
Oh gosh, you'll have to stay tuned too, because I'm involved in some really some projects I'm really, really excited about, sort of some front edge, cutting edge sort of things. So we'll see how things sort of move forward. But I do think there's going to be a role for AI, artificial intelligence, and some data driven pathways. I think the other thing I'm excited about is that we have, as time goes on, we'll have more data regarding the links between blood pressure measurements in youth and how that manifests as blood pressure and disease in adults. So I think that's going to shed some light. And I think more studies that are comprehensively using ambulatory blood pressure monitor data, which gives us measurements during the day and the night, I think that also will be helpful. More vascular studies. So you'll see, we already have some studies using, pulse wave velocity and carotid intermediate thickness and some other augmentation index, things like that. But more of that, we haven't yet used those technologies in general practice. From echo perspective, strain, and some other, ways of looking at the heart. There's some things that are coming down the pike, I think, that will be good to see.
We talked about a lot of different parts of the guidelines and everything from diagnosis to treatment to what not to miss. Do you have any general main take-home points for listeners or things that you want people to really walk away with after listening to this podcast episode?
So please measure the blood pressure correctly. It's just
Nice.
it's really should be the right arm. The normative data is really derived from the right arm. You can compare to other limbs and for comparative measurements, but that's don't discount that kids can have high blood pressure, so it really should be assessed at the well child visits. And use the opportunity when you see, weight increasing across percentiles to really start talking to families before there's dramatic increases in weight, to start talking to families about healthy lifestyle. We just released our hypertension, the AHA statement on the relationship between sleep disordered breathing and cardiovascular health in children. So there is a relationship. So you definitely want to pay attention not only to what happens during the day, but what happens at night in terms of the quality of the child's sleep and whether there's any signs of obstruction, because that also too is related to the cardiovascular health of the child. So, if there's still questions, feel free to go to our very comprehensive 2017 guidelines, which a lot of effort went into creating.
Before we go, do you have anything to plug? Any cool things that you want to actually make sure that our listeners know about?
Oh, cool things related to the heart, or cool things related to anything?
Your heart related, Netflix
your
show,
blog,
anything that you think are.
I just want to plug. I want to put a plug out for Simone Biles and Naomi Osaka, who taught all of us driven people to it's okay to take a mental health break. We all need it. And that is actually a sign of strength. So I'll just plug out to those phenomenal women.
Excellent. Thank you so much.
That's a great ending. Thank you for joining us. This was wonderful. What a great way to kind of review some of the guidelines, learn from the experts. Thanks for joining us tonight.
Well, thank you for having me. I appreciate it.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at thecribsiders.com.
We are committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. Please subscribe, rate, review the show on Apple Podcast, or contact us at thecribsiders@gmail.com. A special thanks to our wonderful producer for this episode, Dr. Crystal Nora, and our wonderful social media team. I've been Justin Lee Burke.
And I've been Crystal Kamtochukwu Nora.
And this has been Christian. This has been Chris Chew. This is me, the Chew Man. Good night.
Hey, you've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by VCU Healthcare Continuing Education. VCU is accredited to provide continuing education to the entire healthcare team. Check it out at cribsiders.vcuhealth.org for more information and to claim your credit after listening to this episode.